Hello and good day. I am Christine and I will be presenting my clinical case study for angiography, which is AG02. And in this case, it is the coronary angiography. So before I proceed, I will briefly introduce my case study first. So my patient is a 49 years old woman referred to the department for cardiological follow-up. The patient has medical history of hypertension and previous myocardial infarction, but there is no history of diabetes, hypercholesterolemia, or premature coronary artery disease in her family. The patient also does not smoke, does not take drugs, and is not on estrogen replacement therapy. So the patient has undergone physical exams and laboratory tests, which the results have no significant findings of abnormalities. The proposed diagnosis for this patient is coronary artery disease, and the gold standard angiography procedure for this patient is coronary angiography. So for the patient preparation, before the procedure, the patient has to kneel per oral NPO 6 hours prior to the procedure. Then a detailed medical history taking will also be done in order to find out whether the patient has previous contrast reactions, or patient has allergy to contrast reactions, or previous episodes of stroke due to contrast reactions. And the patient will also be given explanation on the procedure, a detailed explanation, to make sure the patient understands what she will be going through in this procedure. The patient also has to sign an informed consent form, and if there is any allergies, the patient will be given pre-medication. And also before the procedure, we will take baseline vital signs of the patient, and we also have blood tests to assess the serum creatinine, the PTT, INR, insulin and sugar levels of the patient. So all of these procedures will have to be done before the angiography. As for patient care during the procedure, after the patient lies on the angiography table or the fluoroscopy table, the area of puncture site will be shaved to remove hair, and the puncture site will be cleaned with antiseptic solution. This will be done by the radiologist, and the patient is covered with sterile drapes from the neck down, and only will reveal the puncture site. Then the patient will also be administered local anesthesia so that the patient will not feel any pain during the procedure. Then after the procedure is done, the catheter that we use for the procedure will be removed, and as soon as the catheter is removed, compression will be applied at the puncture site for about 30 minutes to stop the bleeding and to ensure that there is no bleeding afterwards. So patient will remain on bed for a minimum of 4 hours in semi-fowler position. So while the patient remains on bed, we will have to monitor the patient for any signs of bleeding. Then besides that, we'll also monitor vital signs of the patient, and we will also give instructions to the patient on what to do if there is bleeding at the puncture site. So if there is any bleeding, we advise the patient to apply pressure and to call for help immediately. As for the imaging procedure, so first we will have to perform the arterial puncture, which is in this case most commonly we use the femoral artery, usually on the right side, and the puncture will be done using the Seldinger technique. The choice of catheter is Judkins or Amplatz catheter for coronary angiography. Then next is for catheter advancement. When we have successfully punctured the femoral artery and inserted the catheter will be advanced into placement in the aorta and then into the coronary arteries, the right and left. The tip of the catheter will be placed at the ostium of the coronary artery. Then angiographic views can be performed. So movement of catheter is monitored by fluoroscopy, which is the cardiologist will manipulate the catheter while radiographer will control the fluoroscopy machine to take the images of the desired site. When the catheter is in place, the wire can be removed, then contrast can be administered. So the pathway of the catheter is from the puncture site through the femoral artery. The catheter will be advanced to the common iliac artery, then into the abdominal aorta, then up into the aorta, and into the right or the left coronary artery. For the choice of contrast media for this procedure, contrast media is must be low osmolarity and non-ionic, and it will be injected by hand injection, usually performed by the cardiologist also. For the volume, the left coronary artery will have 6 to 8 milliliters of contrast, and the right coronary artery is 3 to 5 milliliters. As for the angiographic views, there are different views for left and right coronary artery. The left coronary artery usually has more views because it is more difficult to visualize the left coronary artery due to the risk of foreshortening of the blood vessels and also the superimposition or overlap of the blood vessels branches. So for left coronary artery, we will have LAO 5 degrees, which is a very shallow oblique, so that the left main coronary artery will be positioned so that we can see the left main coronary artery just off the spine, so it does not superimpose with the spine. Then we have RAO 30 degrees with caudal angulation 20 degrees. This is to view the left circumflex artery and the marginal branches. And for PA or RAO with cranial angulation, this is usually helpful when we want to see the left anterior descending artery to avoid overlapping by other branches. Then LAO 40 degrees with cranial angulation to visualize the left anterior descending and diagonal branch bifurcation. And lastly, we have the LAO 40 with caudal angulation. This is also known as the spider view. In this spider view, we can see the bifurcation of the left main coronary artery, the proximal circumflex arteries, and the left anterior descending. As for the right coronary artery, which is relatively easier compared to the left coronary artery, we have basically 3 views: LAO 45, RAO 45, and then PA. The reason why we have these oblique views is because the heart is not positioned. The heart is positioned in oblique compared to other structures in the body. For example, for chest, we take views of PA because the position is straight, but for heart, the position is actually oblique, and so we have to manipulate the angulation and our projection so that we can visualize all the blood vessels in the heart. That's why we have so many oblique views. So this is an example of RAO for the left coronary arteries. So for this view, RAO 30 degrees with caudal angulation, we can see the circumflex artery and also the marginal branches. Next, for the RAO 30 degrees or PA view, here we can see the left anterior descending artery and its branches without being overlapped with other branches. This is the RAO 30 view, and this is the PA view with cranial angulation 35 degrees. Next is the spider view, which is the LAO 40 degrees with caudal angulation. Here we can demonstrate the bifurcation of the left main coronary artery, the proximal circumflex arteries, left anterior descending artery, and the ramus intermedius. So this is for the right coronary artery. This is in the view RAO 45 degrees. Here it demonstrates the corners, the right coronary artery, the posterior descending artery, and the right marginal artery. So why do we perform angiography, conventional angiography for this patient? It is because conventional angiography is still the gold standard when we want to confirm the presence of coronary artery disease. And this procedure is more suited for high-risk patients with typical symptoms. And when we look at this patient's case, this patient, since she has medical history of hypertension and previous myocardial infarction, so we can categorize this patient as high risk. Then, besides that, for angiography, conventional angiography also provides real-time functional assessment of ischemia by use of fractional flow reserve. Besides that, angiography is also not only diagnostic but also therapeutic. So this allows for ad hoc interventions, which means because it is both diagnostic and therapeutic, so when we detected an abnormality based on the radiologist's decisions, we do not need to schedule for a second procedure for this patient. So maybe the radiologist will be able to decide whether they can provide an interventional procedure for the patient during the procedure instead of scheduling for a second procedure. So that is the advantage of conventional angiography. The alternative for this conventional angiography is CCTA, which is using CT scan, but CCTA is usually for low to moderate risk patients. It is more suitable in emergency cases. It is quick and less invasive, and it also acts as a gatekeeper before invasive procedures. Gatekeeper meaning if CCTA is able to exclude or able to confirm the presence of coronary artery disease using CCTA, then the patient will not have to go to more invasive procedures. That is the meaning of gatekeeper. So why we do not perform CCTA? It is because conventional angiography still acts as the gold standard, and there is no data on patient management based on CT guided angiography directly compared to conventional angio, even though there has been studies that CTA and conventional angiography have similar diagnostic accuracy when it comes to coronary artery disease. It has not yet been demonstrated that management decisions based on CCTA will yield the same or better results for the patients. And that is why CCTA till now it still should be considered as complementary to conventional angiography rather than competing with conventional angio or replacing conventional angio. So that is all from me, and this is the references that I have used for this case study. Thank you.